Okay, let's talk about biliary atresia. Biliary atresia, it is the most common reason for pediatric liver transplantation. Pediatric liver transplantation. Fibro-obliterative destruction of the bile ducts, which leads to cholestasis, associated with absent abnormal gallbladder or ultrasonogram, often present as a newborn with persistent jaundice after 2 weeks of life. Again, newborn with persistent jaundice after 2 weeks of life. Darkening of the urine, alcohol, alcoholic stools, and hepatomegaly. So you have the urine, which is very dark, but you have alcoholic stools and hepatomegaly. Labs are increase in direct bilirubin and GGT. So now the question arises: how does this occurred? Is this congenital or something? This thing fibro-obliterative destruction. Well, it's in newborns. You have either immune-related destruction of this, so either immune-related, or if that child gets the viral infection, so it could be viral-induced destruction of fibro-obliterative destruction of the ducts, or it could also be due to, again, same thing, viral infection, viral illnesses. But this can all lead to this destruction and causing these ducts, fibro-obliterative destruction of the bile ducts. What are you going to see on the biopsy? Now, you were to do a biopsy, right? So in the biopsy, you will see intrahepatic ducts, bile ducts, proliferation, and portal tract edema and fibrosis. So intrahepatic, the ones that are within the hepatocytes, they are intrahepatic bile ducts are going into proliferation, and the portal tract edema has undergone edema and fibrosis. Just with the name fibrosis, so fibrosis. But that's intrahepatic ducts. That's all for the biliary atresia. Let's talk about how you have the hereditary hereditary hyperbilirubinemias. They're all autosomal recessives. First thing is the Gilbert syndrome. Well, the Gilbert, you have a mildly decrease in UDP, glucuronide transferase conjugation. Okay. It is asymptomatic or mild jaundice, usually with stress, illness, or fatigue. So you have to know that this is a mildly decrease. Gilbert, mildly. Najjar, Krigler Najjar, absent UDP, glucuronide transferase activity. So when you have a decrease in activity, you have an increase in unconjugated bilirubin without overt hemolysis. Relatively common, benign condition. But for the Krigler-Najjar syndrome type 1, you have the absent UDP, which present early in life, but some patient may not have a neurological sign later in life. Findings are you have jaundice, kernicterus, unconjugated bilirubin deposits in the brain, in the basal ganglia, and increase in unconjugated bilirubin. Treatment is plasmapheresis. Phototherapy does not conjugate UCB, but does increase in polarity and increase in water solubility. So all they're saying is this phototherapy does not conjugate this, but only makes it more water soluble so that it can go into excretion. Liver transplant is the only option. It's curative. Type 2, on the other hand, you have less severe less severe case, and it responds to phenobarbital. What was phenobarbital doing? It was causing increase in UDP, glucuronide transferase activity, which increases liver enzyme synthesis. Same thing. Which liver enzyme? UDP, glucuronide transferase. Okay, that's for the Klinger-Jar. And then you have the third thing, which is the Dubin-Johnson syndrome. It is conjugated hyperbilirubinemia due to defective liver excretion. Now you're talking about excretion now. These two were all about conjugation. One is mild and one is absent, and one is less severe absent. And here the Dubin-Johnson, it's all about your liver excretion, defective liver excretion. So you will have a pitch dark black, so dark liver due to impaired excretion of epinephrine and metabolites, and this is again benign. And if you look in this image, 3 is here. So this conjugated bilirubin, it wants to go out, but in the Dubin-Johnson, it's not the excretion. There's a defect in liver excretion. And the question is, what is defective? Well, the defect is you have defective canalicular transport proteins. Okay, so again, the other thing is for the dark, pitch dark or black liver. Okay, and now let's talk about the other one, Rotor syndrome. Rotor syndrome is a phenotypically similar to this guy, Dubin-Johnson, but it's milder in presentation without the black liver due to impaired hepatic storage of conjugated bilirubin. So you have the milder form of Dubin-Johnson, and it doesn't have the black liver. So you can group these diseases in like 2 forms. So this is going to group this as a group. You kind of go from there, but you got the main idea here. Okay. Now, if you were to obstruct and you have this stasis, obstructed jaundice leads to bile will flow out, right? So this conjugated bilirubin now, this leaks into the blood, and this would cause, when it leaks to the blood, right, into the blood, it's not going in the feces, right? So when it's not going in the feces, you will have a pale stools. But because it's going into the blood, you're going to have a dark urine. So these patients would have a dark urine, pale stools. And again, because it's going into the blood, it is going to cause pruritus. And the cholesterol is also here, so cholesterol is going to cause your xanthomas and hypercholesterolemias, hypercholesterols. Yeah, pretty much that's all we have here. Let's move on to the next.